Hello and welcome to ID Talk, answers from an infectious disease expert. I'm Dr. Sean Elliott, a pediatric infectious disease specialist with Tucson Medical Center, professor emeritus of pediatrics at the University of Arizona College of Medicine, and medical director of infectious diseases and immunizations at the Arizona chapter of the American Academy of Pediatrics. This podcast has been created to answer questions from our chapter's members about the COVID-19 pandemic and pretty much anything and everything else related to infectious diseases in pediatric patients. Anybody tuning in from outside of Arizona, welcome. Thank you for joining us. So this week is the week of August 21st, and out there in terms of sick patients coming to the emergency department, we are seeing, as with the rest of the country, a slight increase in patients with COVID-19. Not a surge, at least not yet, but certainly an increased number of patients presenting either primarily with respiratory symptoms and positive SARS-CoV-2 and or a co-infection and being evaluated for something in addition. Continue also to see a fair smattering of other respiratory viruses, including rhino/enterovirus and adenovirus, and all the other usual things are certainly still a very significant onslaught to our urgent and emergent care colleagues. This week we have some, again, fabulous, interesting questions. The first one is kind of a nice general one, and it is, can I provide any advice on planning a flu vaccine clinic for the upcoming flu season? Wow, okay, well, I'm not 100% sure how to approach this, other than to say that there are, as with past years, a very large array of flu vaccine products, keeping in mind that they are all now quadrivalent, so 2 serotypes of influenza A and 2 serotypes of influenza B. And this year, again, as in past years, there is now available a live attenuated intranasal vaccine. I've talked on a previous podcast about indications for that vaccine, and it is certainly reserved for children ages 2 years and up without any underlying respiratory illness, chronic reactive airway disease, asthma, or immunodeficiencies. And if you wish to find a very definitive list of contraindications for the live attenuated intranasal vaccine, you can certainly find that online through the AAP or even just CDC. And that's just a simple search, LAIV, on a Google search should bring that right up. Many other products, though, also including for those who may have an egg protein or ovalbumin sensitivity or allergy. And this also has been covered in a prior podcast. Yes, indeed, the ACIP, as one of its voting actions this past summer, is now officially recommending flu vaccine everybody ages 6 months and up, and even including those who have a known ovalbumin or egg allergy, because there are products available on the market and can be ordered to your practices for exactly those patients that have no ovalbumin in them whatsoever. So there are a lot of products. I'm assuming or sure that everyone's clinic has their own ordering process and either already has orders placed and or are anticipating that. Typically, flu vaccines can be available and delivered in September. Most often, people start their flu vaccinations of patients beginning in October. The anticipation is to provide seroprotection from that flu vaccine for at least 6 months. That's about as long as a highly protective seroprotective response lasts with the various quadrivalent vaccines available on the market. So if you start in early October, that patient will certainly be well protected into spring, certainly March or so, and that's a reasonable time frame to cover patients. Immunizing on into November, absolutely, of course. We really start to see the major increase in cases as early as late October here in Arizona, earlier in other parts of the country if you're tuning in from there, and certainly by November, it's a pretty fair bet that we'll be seeing a decent number of influenza cases, both A and B. So in terms of planning timing of the vaccine clinic, I think it is reasonable to get your ducks in a row and be ready to go by early October and to start vaccinating your patient population as early as mid to late October. Earlier, if you happen to catch them there for another reason, like a planned anticipatory guidance or preventative healthcare visit. This year as well, I think this may be part of the question too, is the anticipation that it won't just be a flu vaccine, but there will be also opportunity to immunize for the first time or potentially re-immunize patients against SARS-CoV-2. And certainly that is a fabulous opportunity. It's a 1-2 punch, not literally, opportunity to get both COVID and flu vaccines into our pediatric patients' arms. To remind you, things have changed a little bit with the current Pfizer and Moderna mRNA bivalent vaccine products. For a first immunized baby from 6 months to 4 years of age, it's the typical series. So a 3-dose series with the Pfizer bivalent, a 2-dose series with the Moderna. Beginning, however, at age 5 years, for Pfizer specifically, the Pfizer mRNA bivalent current vaccine, it is a 1-dose series for primary vaccination, meaning first time ever experiencing a vaccination against COVID-19, ages 5 and up, it's a 1-dose Pfizer dose with that bivalent. With Moderna, it is still a 2-dose for ages 5, and then beginning at age 6 and up, it is a 1-dose series of the Moderna. So again, it may sound a little bit confusing, but we're certainly trending toward a single-dose primary vaccine series beginning at age 5 for Pfizer and beginning at age 6 for Moderna. If you wish to, the AAP and the CDC have a lovely quick reference guide, which again you can download from a simple Google search. Just look for up-to-date vaccine recommendations, COVID-19 pediatrics or something similar, and that'll probably be one of the first hits which comes up. That also has further recommendations for those who are previously vaccinated and may be due for a booster. Is there a need for a booster this year? Yes. Because prior vaccines, especially for kids who've been vaccinated with prior surges and are maybe a couple years out, what is circulating out there are additional new strains of the BAs like the XBBs, etc. And the currently proposed advanced mRNA vaccines from both Pfizer and Moderna is going to include the XBB.1.5, which will provide really broad coverage for a lot of the newly emerging sub-isolates of the Omicron variant. So a patient who's not received or will not have received the newest Pfizer or Moderna COVID vaccine is likely due for that beginning this fall, and those vaccines are anticipated to be available by mid to late September. So one might consider broadening your flu vaccine clinic to be flu and COVID-19. Putting aside for the moment RSV only because that is coming up in the next question. But that seems to be a reasonable approach to go for. And as always, that's also a fabulous opportunity to make sure the kiddos are up to date on all their other routine vaccines. Obviously, we know this, and we grab them at every opportunity when they're in the office, and or even just coming through if you happen to do this, a drive-through shot clinic. That sounds reasonable as well. So anyway, thank you for that question. Hopefully I addressed what you were asking. If not, let me know, and we'll hit it in a subsequent podcast. Then question 2, speaking of RSV, AAP is recommending all infants under age 8 months receive the new monoclonal antibody nirsevimab, or Beyfortus if you like the product name, to protect them from RSV. Can we review the timing for when this should be administered? So the vaccine, and this is sort of a nuance of science, but nirsevimab is a monoclonal antibody. It's passive vaccination, so we're giving antibody, not triggering the creation of antibody by the baby's own immune system. It's why it is immediately successful, because we're giving them immediate immunity with the monoclonal antibody specific for a stable antigen of the respiratory syncytial virus capsule. So that's great, that's wonderful, that's fantastic. But as with any antibody, either injection or infusion, for example, intravenous immunoglobulin G, there's a finite life to that because the human body, like all other proteins, excretes proteins, including monoclonal antibodies. So the anticipated proven, evidence-based proven efficacy of nirsevimab as this newest monoclonal antibody is upwards of 80-90% up to 6 months after injection. After that, it drops. It's still very good. I mean, at 9 months out from injection, it's felt to be around 65% or so. So these are fabulous numbers, and it's just a matter of timing the vaccine or the nirsevimab to get into your patient's arm or leg, as the case may be, with enough time to go through the RSV season. So that's why I mentioned with the prior question in the fall, this may be a good opportunity to get the babies from birth up to 8 months of age with nirsevimab. Certainly vaccinating them with this product in September, October will anticipate and provide protection for the upcoming RSV season, which also lasts from October through usually into March or even April. So that's a fabulous time to update that. Very interestingly, earlier this week, the ACIP provided formal and final approval of the Maternal RSV vaccine. Now, that is a true vaccine, and that is, of course, protective for the moms at a mom or expecting moms at a time when they may be partially immunosuppressed, but it also provides fantastic coverage for baby in utero and then postpartum protection again for a good 6 to 9 months or so. So it's going to be interesting as we wait for the final CDC approval, which I expect is coming any day now, and then for those recommendations to be picked up by ACOG, the American College of Obstetrics and Gynecology, as our expectant moms hopefully become far more universally vaccinated against RSV in the same timing. We will have a cohort of babies who should have maternal IgG protection from that maternal vaccine and who won't necessarily need the nirsevimab. Me being a belts and suspenders kind of guy, I'm kind of like, what the hey, give them both. But that, of course, is costly and an injection for baby. So with the grain of salt or the sort of heads up that there may be babies who have protection already from maternal vaccine, if not, then anywhere in the couple months to certainly a month prior to typical onset of RSV season, that being the late fall, we're talking October and certainly by November, would be a fabulous time to provide nirsevimab to the babies. And this is for their first RSV season. The recommendation, and this is now official recommendation, ACIP, CDC, FDA, etc., and AAP too, is that all babies under age 8 months get nirsevimab prior to their first RSV season, and then all those babies who have the typical complex comorbidities putting them at risk for severe RSV should get a repeat dose prior to their second RSV season. Complex patients, just like we have with palivizumab, so known former premature infants, certainly those under 25 weeks of age, up to 28 to 35 weeks, those with chronic lung disease due to other reasons, chronic asthmatics already, that'd be difficult for a brand new baby, but certainly that who has a severe reactive airway disease component, and those with complex congenital and cyanotic heart lesions would all deserve that. So that's a whole bunch of nirsevimab, and yay, fantastic, wonderful. We have, I think, a huge potential to change the face of the RSV season in pediatrics in this country, and that can only be a fabulously wonderful thing. The other question, of course, is going to be cost. Now, ACIP and CDC did vote to include nirsevimab in VFC, Vaccines for Children. So that should mean a lower pricing structure for sure, and it should mean for those VFC kids that their doses should be covered. Yet to be seen is how much the commercial insurance industry will support that, and other access patients if for whatever reason those kids don't qualify for VFC. So to be determined the actual cost delivered to the patient. However, that cost versus the risk of severe outcomes with RSV and the cost of a hospitalization, and including potentially a pediatric ICU hospitalization, to me would support this universal vaccine strategy with nirsevimab, again, in the late fall or even early fall if that's when you happen to have that baby in front of you in the practice. Cool. All right. Let's move on then to something completely different. Thank you. And this question reads, mosquitoes that carry West Nile virus are becoming resistant to insecticides. Do I anticipate we will be seeing more mosquito-borne illnesses in the coming years? Short answer to that is yes, and not just because of resistance to insecticides, but also in terms of our increasing global warming patterns and increasing mosquito burden. Specific to the mosquito, which is the West Nile virus carrier, that is the Culex mosquito. And yes, we do have those here in Arizona. Certainly the rest of the country does as well. And that mosquito burden is increasing in part, maybe resistance to commonly used insecticides, but also, again, we're warmer, we're more moist. We've certainly had greater, recently, of course, onslaught of tropical storms, all of which increase the mosquito burden and increasing the infected mosquito burden carrying such viruses as West Nile virus. So for several reasons then, yes, absolutely, I anticipate we will be seeing an increase in West Nile virus cases, and we're already seeing that in the adult world here in Arizona, and I'm sure in the rest of the country as well. Not just West Nile virus, and so the Aedes aegypti and Aedes albopictus mosquitoes, which are the known carriers of Zika, dengue, chikungunya, and a couple others, those are certainly quite prevalent across the border. For Arizona, in Sonora, Mexico, so right across the border, and we have those mosquitoes in generous distributions here in Arizona as well, certainly for the lower half to even lower 2/3 of Arizona. Not quite so much in northern Arizona, at least not yet, but anybody who's living and practicing in Maricopa County on down and the entire southern part of the state has those mosquitoes already present in their communities. And increasingly, those mosquitoes will be acquiring increasing burdens of Zika, dengue virus, and chikungunya virus. So we can expect to see increasing numbers of those those infections as well. Also, sorry, we're not done yet. There are other viruses traditionally carried by mosquito vectors, and at least in Arizona, that includes Western equine encephalitis and St. Louis encephalitis viruses. In other parts of the country, for those tuning in, the Eastern equine encephalitis virus, which is of all the equine encephalitis viruses, the most nasty, certainly carries a high degree of morbidity and mortality, loss of respiratory drive, need for intubation, ventilatory support, ICU stays, etc. For the others, they're fairly, and this is in a huge air quotes, fairly benign, similar to West Nile virus and potentially a Zika virus in our pediatric patients. And so fevers, headaches, some rash, myalgias, malaise, your typical severe flu-like illness. So, yeah, sorry, I do not anticipate any decrease in mosquito/vector-associated infections in the near or even long-term future, and it behooves us then to be aware of and to consider screening practices for all of those mosquito-borne illnesses and infectious diseases. As we start to see true increase in those numbers, you can expect to see released to you a health advisory network notice from the Arizona Department of Health Services, because they track those numbers. They track them based on laboratory testing sent to the state laboratory by providers who are on the lookout for these, such as your friendly local infectious disease specialist. And as they start to see an increase in numbers, then that will trigger a HAN notice so that all of us can be in the lookout. I would suggest we go ahead and keep our eyes open as well. So that patient coming to you with fever and a flu-like illness persisting for a couple days, and certainly with severe myalgias and polyarthralgias, ask the mosquito history. If they have had lots of mosquito bites, and certainly if they've had lots of mosquito bites across the border on a visit or coming across the border to visit us, that is a patient who deserves testing coordinated through the state health department and through the state lab with a triplex PCR, which includes Zika, chikungunya, and dengue. So anyway, thank you for that question. Yeah, we got that coming. And then final question, what potential measures should providers like myself follow when responding to simultaneous outbreaks of Listeria and E. coli? Oh boy, yeah. So once again, if we ever thought that infectious diseases was a dying or an inert field, we thought wrong. There are clusters of cases or outbreaks of cases of pretty much everything, fungi, bacteria, viruses, prions, etc., on a very regular basis. So currently, yes, there have been clusters of an enterohemorrhagic E. coli occurring not yet so far in Arizona, but not too far from here, so as close as Texas and potentially parts of New Mexico, and certainly other parts of the country. So not the E. coli O15787 or the O111H11 of recent enterohemorrhagic E. coli fame, but a new one, and it has the same associated risk of hemolytic uremic syndrome. So, wow, what steps do we take to respond? Awareness. So asking the question is the very first best thing, and thank you very much for that question. So awareness of that patient who has bloody diarrhea, especially associated with severe crampy pain. We're talking severe, like, hunched over screaming for the children, or legs to chest, almost like a TET spell, or just severe tenesmus, so pain as or prior to defecation. Those patients deserve treatment, deserve testing for Shiga toxin, which is available at many of your referral hospitals with a GI pathogen PCR panel. The one at my institution is quite robust and includes testing for Salmonella, Shigella, and Shiga toxin. If one is suspicious of an enterohemorrhagic E. coli infection, absolutely do not treat with antibiotics and do not treat with anti-motility agents, because those will increase the burden of toxin release and increase the risk of hemolytic uremic syndrome. So that would be for E. coli causing enterohemorrhagic disease. Yep, there are other E. colis out there. We are certainly seeing, perhaps the reference of E. coli and Listeria, seeing an increase in neonatal sepsis. This has been an ongoing trend since we got really quite robust at screening for and treating moms who are group B strep positive. Nature abhors a vacuum, and into that vacuum comes E. coli, and the E. coli is increasingly resistant to routine antibiotics, because many of our adults and our mothers have been experiencing polypharmacy, multiple antibiotics, etc. So the neonate coming to you, so certainly in the first 21 days of life, we do everything as per the new protocol released by the AAP. So everything meaning, blood, urine, CSF, you name it, empiric antibiotics, empiric treatment, empiric hospitalization. And from 22 days up to then, the first 2 months of life, in decreasing levels of aggressiveness, we are still doing cultures and looking for E. coli. Listeria is or has been the subject of prior outbreaks and typically, of course, associated with dairy products. Its prevalence, its incidence in pediatric neonates or like babies as a source of neonatal sepsis and meningitis has decreased significantly over the past decade or so, to the point where those of us who are sitting our MOC boards, when asked about typical causes of neonatal meningitis, are supposed to say group E. strep and E. coli and no longer listeria. That said, there are still going to be clusters. And so here again, we depend upon our friendly public health officers, both local, regional, county, and state, to let us know when there's a local cluster. So what can you do to prepare for this when responding to either an active outbreak or a potential outbreak is tune in to your local health department's either website, listserv if they maintain one, and just stay up to date on what is currently circulating in your practice area. And then, of course, respond or treat accordingly. Typical public health notices when something's emerging include not only information about what it is that's outbreaking or emerging, but also initial steps for management, whom to contact, and how to respond. And if you have any questions whatsoever, and of course my ID colleagues are probably cringing right now, but we are truly here to talk to you about those concerns and to help as best we can provide some guidance for management and our response to a suspected patient with something from a local outbreak, including E. coli and including listeria. So thanks for asking that question. Basically, communication, staying in touch with your health department, either through their websites or listservs, asking questions if you need to, and basically being alert. That is truly the best thing I think any of us can do. So thank you for the questions, and thank all of you again for listening to ID Talk. Arizona AAP members can submit questions for future episodes to covid@azaap.org. The Arizona AAP would like to acknowledge the generous support of this podcast by the Arizona Department of Health Services through the Title V Maternal and Child Health Services Block Grant funding. For more information and resources related to COVID-19 in Arizona and other infectious diseases, or to learn how to become a member, please visit us at azaap.org. And in the meantime, and as always, keep hanging in there, keep the questions coming, keep fighting the good fight, and thank all of you for your service.